Link on thing. Welcome you all to this yet another interesting topic on the congenital hand, which is always intriguing and very challenging, especially in the field of hand surgery, deal with young children. We have three very eminent panelists who have been very pioneering in this field. We have Professor Dr. Bhaskaran sir, who was the past president of our Indian Society for Surgery of the Hand, and who has his excellent contribution in the field of congenital hand. His passion is that he always teaches with enthusiasm and very passionate in doing all congenital hand cases. We have learned a lot from him, especially the polycystation in congenital hand and other surgeries. So we'll have a great time with him. Dr. Bhaskaran sir will start the program. Along with, we have two other speakers. Dr. Jane Shen from China. She's the associate professor in the Department of Orthopedics and Hand Surgery. She's been doing a lot of very innovative and interesting and functionally improved a lot of congenital hand surgeries, and we have been seeing her in many of the talks around the world, and we are happy and privileged to have here. To add up to this flavor, we have Dr. Takiko Takagi from Japan. He has a very impressive, short biodata he gave to me. He has been trained in various renowned institutes in the world, right from Kleiner to Louisville to other institutes in the world. And currently, he is the division head of the Department of Congenital Hand Surgery in Tokyo. So we have three eminent panelists here who's there to talk about the nuances of congenital deformities, namely the cleft hand and the mirror hand. We will have first Professor Bhaskaran said to have his talk on the mirror hand.
Very good. Thank you very much, Dr. Terrence. It was very kind of you. Nice, sweet words about me. You only talk about the good habits that I have treated. You do not know how many I have spoiled. Mirror hand is once a challenge. It's normally told that one hand surgeon may see one mirror hand in his lifetime, one or two. I was lucky in Manipal when I was there. I saw 2 cases. Subsequently, because of my trip to Tirupati as well as Dwarka Tirumala, I jumped around hospitals where I had the opportunity of seeing more. Resulting in duplication of the digits with no thumb. It's all fingers and no thumb. That's why the problem of using the hand. Crowded fingers, or I almost call it banana hand. But the terminology is also, the popular terminology is called ulnar dymania, because in the forearm, ulna gets duplicated. And this duplication of the ulna, because of that, we call it ulnar dymania. And if you see, that's how it is. Here we have 6 fingers and actually double ulna. The carpal bones fused a lot. If you look at the hands, there may be 6 digits to 8 digits. I have seen only or this is 8 digits as an example, you will realize that those on the medial side, those digits are almost normal. Digits on the so-called lateral side or pre-axial side, though there are 4, they are not normal. I had a total number of 13 cases treated at various centers. We had 2 cases of 8 digits. In 7 cases of 7 digits, we had 6 cases, and 6 digits, we had 5 cases. As I told you, lateral digits may show biphalangealism, syndactyly, phenodactyly, etc. to be present, as an example here. And quite a few occasions, the lateral digits are abnormal. And so other pictures may not be there, but you see on the wrist joint there is a little bit of callosity and this is flexed, about which we will talk later. Hand skeletons, there may be metacarpals for all the digits, but sometimes metacarpals may be single or double, or for the 3 digits, there may be no metacarpal symptoms. So varied presentations are available. Each digit may have its own independent metacarpal. If you look at the wrist, it's often flexed. Dorsiflex of the wrist are very much weak. And when we open sometimes, we find that they are very flimsy. So much so that they are about 14 years, etc., when they come down, we have realized they are almost like parchment adherent to the compartment. So it's flexed like this. And you see the velocity here. We had one patient with a normal wrist that he had a variant mirror hand where he had double radius fused. So the wrist was almost normal. He had Manus valve. Manus valve is a one patient. And usually there is flexion deformity of the wrist. We had 8 cases, wrist velocity 6. Carpal bones show duplication, symmetric duplication, of course, especially the ulnar elements. So, and we have the 2 physobones, 2 triquetrums, and hamets. So they may be fused, as you see here. The central capitate and the lunate will be fused or separated. Scaphoid trapezium are always absent because the radial side or the lateral side structures are not there. A head plastic trapezoid may be present. If you look at the ulna, though there are 2, they are rotated 70 degrees axially, so 180 degrees of each other. Since it is not rotated, quite often the elbow is stiff. Elbow is never normal in these patients. It permits only limited motion. The ulnae may be almost looking equal, or the lateral one is often hypoplastic. This is a case of double radius which was fused. Sorry for the very unclear. It's one of the very old patient of mine by Jerome. He had double fused radius. This joint was present. It was more stable. What we did was we polycized its lateral digits, then lengthened the radius. One patient had 3 bones in the forearm, and you see here. To one, the lateral digit, lateral 2 forearm bones are fused proximally, and one in the center almost is very flimsy. So this is how it is, and distally they are looking almost like broad like radius. So ulnar with double radius, the fused radius, they are 1. 3 ulnae and lateral 2 fused proximally 1. Medial lateral ulnar of equal size in 3, and lateral hypoplastic in 7. Medial normal, lateral hypoplastic plus proximal sinus 1. Range of movements are often limited from a fixed flexion deformity of 20 degrees and may permit 30 to 40 degrees of for the pec because the ulnae are not in normal position. As you see here, there is a synostosis of the proximal part of the two ulnae. It's not that only the forearm and hand and wrist are involved, but scapula and clavicle may be have clot. Femoral head may be small in some cases. Glenoid fossa may look bigger in some other cases. In one case, we had even dislocation of the shoulder because here a small hypoplastic head and the glenoid being big, and the one on the right side shows dislocation of the shoulder. So bigger glenoid, we had one hypoplastic in 9, dislocated in 1, and normal only in 2. So in other words, middle hand is a problem right from the shoulder down to the fingers and the problems. Of course, the problems are more on the axial radial side, that is the lateral side, than on the medial side. Medial side digits are often normal. In our management, creation of a thumb is one of the most important things. Achieving functional position for the wrist, the next one. Attempting to get useful range of movement at the elbow, the third priority. As far as shoulder is concerned, you will not be able to do anything. If there is a dislocation, there is no question of relieving it. As I told you, total number of cases were 13. And we could treat 9 patients by polysalizations. Those are it for the study. And just some examples of cases. There are 6 digits here. That is a post-polysalization. A girl with 7 digits. That is the result of the polysalization. So she was, when we did the surgery, she was 10 years. And this is at the age of 16 years, we have taken these photographs. At another one who had double radius, variant of mirror hand, which is published in the Journal of Hand Surgery. And after polysalization, we lengthen the forearm. That's the function. Lengthen the radius. That's the function. This is this girl's hand after polysalization and X-ray. Achieving function of the position of the wrist is very important. In fact, most of our children came to us for that say a later date, and where we did a lengthening the osteotomy in 3 cases to keep the wrist in better position, and lengthening of the fused double radius in 1 case. As I told you, when we did the dorsal wedge dorsal, we were surprised to see that most of the tendons there were virtually adherent to the compartment, not be separated. And I did a dorsal wedge osteotomy, and that is the position that we got to stop it. So it was so much flexed, the one on the left side, the other side, you will see it's corrected. Lengthening of the fused radius. We have attempted to get a better movement at the elbow joint by exercising the proximal part of the lateral ulna, but our results were not of much success. In fact, I repented having done surgery in 1 case because it was more stiff. Thank you very much. Yeah. Yes, Terrence, I think I have stuck to the time that you have given me, 15 minutes. Yeah.
Thank you, Professor Dr. Paskaran, for your very wonderful talk. Especially the girl with the 7 hand children. 7 hand is almost amazing. The results are so warm, welcoming, and to see that these deformities can definitely be treated is very much appealing to the congenital hand surgery and people who are really interested in doing congenital hand surgery. Thank you very much, sir. Next, we have Dr. Jen Shen from China. She'll be talking about the cleft hand.
continue in this video. So,
Invitation to today's presentation. I'm Xiaofang from China, and I am a pediatric hand surgeon. It's a really appreciate. Today's my presentation is talk about cleft hand. Cleft hand or central longitudinal deficiency is a variable absence or an abnormal formation of the central ray of the hand. And today's my talk, my presentation is three parts of the first is classification and my preference techniques and conclusion. We know classification of the cleft hand is two classifications. So first one, masking and original. Masking's classification is based on the quality of the first web space. Type 1, normal first web space. Type 2, a middle narrowed first web space. Type 2B, moderately narrowed first web space. And type 3, syndactylized first web space. Type 4, merged with cleft. Type 5, absent web. And organ classification is based on the bony central deficiency. And cleft type 1 is cleft hand without a missing digit. Type 2 is defect of a single finger ray. Type 3 defect of 2 finger rays. Type 4 defect of 3 finger rays. And type 5 defect of 4 finger rays. And this picture shows different type. And to left masking classification, we can see type 1, 2A, 2B, 3, and 4. Original classification is different. I can look at the pictures. This the boys bilateral thumb. The first web is normal, but he defect three fingers. And some different types like this type. Some another different spatial types like this type is syndactyly 1, 2, 3 fingers, and is index finger is it has a deviation. So today we talk about the goals of reconstruction. Close down the cleft, creation of a wide, well-controlled first web space, preservation or construction of a mobile, unscared, and stable thumb, transposition of the index ray to the underside of the cleft, correction of index meltation or deviation, preservation of an intact adductor polycystic muscle, creation of a satisfactory appearance. So, this is I share some my experience of treatment of different type. Type 1 is normal, have normal. It's the first space. The first web space. The deeper transverse metacarpal ligament is reconstructed by using the flexor sheath, part of the A20, A10, A2 polis of the index and the ring fingers. I should say this is flexor sheath, and this before X-ray, before operations X-ray. And after 27 months follow-up, the girl's hand can cross down the first cross down the cleft. And type 2A. Type 2A, I like the snow little procedure. The cleft is raised as a palmar-based flap, and this is a small radial flap preserved for recreation of the commission. Slow little procedure can use several types of cleft hand. And in the operation, the second metacarpal is transposed and fixed to the remnant of the base of the third metacarpal. The palmar flap is then transferred and the new commission between the second and fourth rays recreated. After several months follow-up. And the type 2B, the first web space is released, which may require division of the first dorsal interosseous origin and the surrounding facial skin graft reconstruction is the first web. This picture shows the boys after 5 years follow-up. And technique type 3. I also use the snow little procedure. The snow little procedure combined with syndactyl release. And the cleft is raised as a palmar-based flap with a small radial. This as a small radial flap preserved for recreation of the commotion. And the second metacarpal is transposed and fixed to the remnant of the base of the third metacarpal. Transposition of the index on top of the round metacarpal keep adductor pollicis muscle. Adductor pollicis muscles keep let them thumb and index finger can pinch it. After 3 months follow-up, the boy can normally thumb and the index fingers function, and a good open the first web space. I introduced some spatial types. This case is bilateral hand difference. His right hand thumb and index finger deviation, and thumb and index finger and round finger is syndactyl. I did the first stage, release the first web and dorsal flap reconstruction. This case needs next surgery to release the index and the round fingers, and correction is index fingers deviation next surgeries. And this his picture is his left hand. Left hand is a complicated syndactyl. I did a one-stage release 2 web and skin graft. I designed the dorsal flap and releases the second and the third web in the operation after the operation. And these 2 pictures shows after 3 months follow-up. his mother just sent me his hand pictures today. My preference. The snow-little procedure is my favorite surgery procedure in treatment cleft hand. And Fred said the cleft hand is a function and a social disaster. Yes, I agree. I know many parents told me since their baby's hand function is okay, they can, but because to go to school, go to school, their child is sad. So we design more surgeries, treatment to obtain 5 fingers. Obtain the 5 normal fingers is our the surgeries. Creation of a satisfactory appearance more important in Chinese family. Thank you for your attention. Thank you, Terrence.
Yep. Thank you for your amazing talk. It was really amazing and very interesting to see the follow-up. As rightly said, cleft hand is a functional triumph and a big social disaster. To have such a defect, especially in a family, the parents are much worried. And even though they did not know that this such a cleft hand can be reconstructed, so it's definitely a worthwhile surgery. All your results are very very interesting and very good. Thanks for joining us. We have the other speaker, Dr. Takegi. No, actually, he wants to talk more about the cleft and the mirror hand. But then he had his own passion in talking about the nerve machine interface and target muscle reinnervation, which is currently pursuing as a research in his hospital. So he's going to talk about that. Dr. Takiko Takagi, please go ahead.
Can you hear me? Oh, it's my great pleasure to present our recent study of TMR. My name is Saki Takagi from Japan. I'm currently working for the National Children's Center in Japan as a pediatric surgeon. So I treat a variety of congenital differences: protein thumb, cleft hand, syndactyly, brachydactyly, constriction, macrodactyly. Here, I took one example: severe type of hypoplastic thumb, so-called floating thumb. This is a great review paper of some hypoplasia by Dr. Soldado, Dr. Ludlow, and Dr. Scott Cozen. They also wrote the treatment for each type. Type 3B or 4 is going to the politicization. I also agree that it's a gold standard. However, the most parents here in Japan have hoped for keeping thumb since long time ago. So we have managed to think the reconstruction. By the way, about type 3A with a stable TMC joint, we all agree. For 3A, we usually do muscle transfer, hypostenar muscle transfer to the sternal muscle for strengthening folding function. About type 4 with the absent thumb, we all agree the politicization. That means index finger transfer to thumb for acquiring folding function. This is the background of the approach. We currently use the so-called Ezaki design. We usually refer to Dr. Cozen's paper and his video in the Green's operative hand surgery. So I go back to the subject of types 3B and 4. The politicization is a gold standard. Although functional results of the politicization are satisfied, majority of the family desires to keep the disease number. For responding the patient's hope, we have traditionally challenged some preserving and reconstruction as two-stage reconstruction. The first, bone graft, and the second, muscular tendon transfers. There have been several reports so far. For example, Professor Yabe performed the non-vascularized false metatarsal bone graft followed by hyoponenoplasty. Dr. Chow in 2011 used the half-sweep metatarsal bone. That's an interesting idea. We have applied Dr. Yabe's procedure for the severe thumb hyperplasia for a long time. This is a summary of the surgical procedure. On the first stage, non-vascularized false metatarsal head is transplanted to the first metacarpal base to reconstruct the CMC joint with or without the first waveplasty using a dorsal sliding flap. On the second stage, it was performed about 6 months after the first one. An ADM opponentoplasty was carried out. Recently, we also performed extensor tendon transfer with EIP and flexor tendon transfer with FDS to the ring finger were also added. In details, you can refer our technical article in press. It seems to be impossible to keep such a floating thumb. However, a floating thumb has a neurovascular band in its pedicle. And here we identified and divided the band with tender care for preservation. This is about missing thumbs. How about the missing upper limbs? We sometimes have congenital amputees, so-called transverse deficiencies like these. These are the adult cases with high energy trauma on, for example, traffic accident. Just 100 years ago, Krukenberg developed the operation for the amputees. Forearm muscles are separated into two groups for making open and closure of forearm. These figures are from an SSH textbook. He can grasp the cup. Pencil. It's Bangladesh sand and papers. But as I told you, in my country, we prefer to improve appearance, and the parents cannot accept such a surgery. Hand transplantation is a great option. In a child case, an 8-year-old boy who had contracted staphylococcal sepsis with a systemic ischemic injury at the age of 2 years had bilateral hand transplantation. The report was released just 2 months ago. Oh, no, sorry. Just 2017 from Cozen's group, the Children's Hospital of Philadelphia. He has a good outcome. However, sometimes there is immune reaction with rash or erythema. Some surgical treatment has been reported so far, but it's difficult to accept them in Japan. Therefore, we focused on the prosthesis. It's a trial for child. One sensor on the near lateral epicondyle and the other sensor near the medial epicondyle. If a man extends the fingers, a sensor on the lateral epicondyle is detected and the fingers' prostheses are extended. So if the amputation is on the forearm, the muscle left in the proximal forearm or the elbow can convert into the motions of the prosthesis. Even if we can't make the arm for them, we thought it would be possible to use myoelectronic arm. So we focused on myoelectronic arm that is controlled with the electronic signals generated naturally by remaining muscles. Moreover, Dr. Kaiken developed the concept of target muscle reinnervation, TMR. The concept is that the amputated nerves transfer to the muscles to myoelectronic hand motions, which relies on skin surface electromyography for signal acquisition. After detecting surface EMG form the transferred nerve. We focused on it. This talk is for traumatic amputees, not congenital deficiencies. Transradial amphi, it means amputated at proximal forearm, is good for acquiring electrical signals for hand motions because the muscles work in hand motion and preserved in proximal forearm. How about transfemoral amphi or shoulder disarticulation? The muscles for hand motion are not preserved, but the nerves are still left. The nerves are median, radial, and ulnar nerves, which act a variety of hand motions. We want to use these nerves for hand motions of prosthesis. Here is a sums of the median, ulnar, radial nerve, or the transhumeral amphi, and transfer to the nerve that innervated muscle in the arm. After successful neurotization, the newly innervated muscle serves to amplify the electrical signal from the amputated nerve. I show you an example rehabilitation institute of Chicago, Northwestern University. This is a nerve coaptation of median nerve to nerve into the medial biceps. This is already reported nerve transfer for TMR. However, there remains some problems. The first, caliber. The diameter of the nerve apparently mismatched. Coaptation of the large donor nerve, blue arrow, to small motor nerve, green arrow. In conventional TMR, large nerves, 8 to 10 millimeters in diameter, containing many thousands of motor neurons, and transfer the small, I think under 1 millimeter in diameter, distal motor nerves that innervate relatively small region of muscle, greatly increasing the odds of any individual muscle particle being re-innervated. The second problem is the selectivity of the nerve. For example, median nerve transfers the nerve into medial biceps, but the main trunk of median nerve includes the fascicles to pronator, digital flexion, and sensory. The nerve trunk transfers a very thin nerve. It's not so effective. We need for more selective motor fascicle transfer to achieve more intuitive control of a highly developed prosthetic arm because selective fascicle is a part of major nerve such as median nerve. For example, this is our case of transhumeral amphi. At first, we expose the radial nerve from the posterior approach. We can use topogram, identify some fascicle from the textbook by Sundaram. And more, we identify the sensory fascicle of the distal radial nerve as distinguished from motor fascicles using somatosensory evoked potential, SSEP. We can distinguish a shape of wave of sensory fascicles from motor ones. After dividing sensory fascicle, we can divide ECR supinator fascicle and posterior interosseous nerve PIN fascicle using topogram. ECR supinator fascicle transfers the lateral head branch of triceps for wrist extension supination. PIN fascicle transfers the medial head branch of triceps for disease extension. And we keep the long head of triceps as it is for elbow extension. In actual photos of posterior approach, ECR supinator fascicle transfers the lateral head branch of triceps. PIN transfers the medial head branch of triceps. And we keep the long head triceps as it is for elbow extension. Next is medial approach for exposing median nerve. We can also use SSCP and topogram to identify some fascicles. FCR pronator teres fascicle transfers the branch of brachialis for reflection and pronation. AIN fascicle transfers the medial head branch of triceps, the red one, for this flexion. And we keep the short head of biceps as it is for elbow flexion. In actual photos or medial approach, FCR pronator teres fascicle transfers the branch of brachialis. AIN fascicle transfers the branch of long head of biceps. And we keep the short head of biceps as it is for elbow flexion. Interestingly, need EMG 6 months after surgery showed reinnervating target muscles, spination, pronation, this extension, and flexion. There's no time left. So one example of pronation, the lower right one, the pronation. I tell him to turn down the palm. The muscle after nerve transfer from pronator teres fascicle. All transferred nerve almost completed 1 year after surgery. So he can do 6 motions: elbow flexion, extension, from pronation, supination, and pronation again, and finger flexion, extension, and finger flexion again, and elbow flexion. I collaborated with process engineers. They developed 6 motion processes for transfemoral amputees. The microscopic findings. He tries to flex elbow and flex fingers. Another part of contracted. And pronation and side. He tries to extend the elbow and extend the fingers. Another part was contracted. And supination. It's 1 year after surgery. He also does therapy as well. We also investigated the DASH score and the functional study. We wrote a paper including those results. Intuitive process control with TMR offers a potentially significant functional psychological benefit. TMR is a novel approach of hand surgeons for amputee patients. Our TMR course was held in Chicago in 2016, 5 years ago. He is Dr. Kaiken. Also, it was held in 2018. I had a presentation of our safety nerve transfers for the processes. I have talked TMR for acquired amputees for the adult caused by, for example, traffic accidents. How about the TMR for the congenital amputees? Congenital amputees cortex possesses sufficient remodeling potential to acquire control of new limb if performed at a young age. However, nobody knows nerve running for the rest of these motions in the radial limbs of the congenital amputees. But we may indicate for the amputees caused by constriction band syndrome that may generate during the late pregnancy. There are a variety of strategies for these for moving processes efficiently. This is an osseointegration. This is not only for stabilizing the processes, but also for embedding the electrode from the sensory nerve for the sensor feedback. This is the RPNI from University of Michigan. They do the free mass graft and wrap around the nerve. They tell the axon will that axon will regenerate within the muscle. I visited there as an SSH traveling fellow in 2017. This is Professor Serzelna's Facebook page. This is the last slide. I collaborated with prosthesis engineers. They developed highly developed prosthetic arm, that is a 6-motion prosthesis for transhumeral amputees. We believe mass nerve transfers, as I talked today, are required for highly developed prosthesis with multiple degrees of freedom. That's all. Thank you very much for your attention. Stay safe and take care. Thank you very much.
Thank you, Dr. Takagi. It was wonderful and opened up our mind, especially dealing with the transhumeral amputees. It was amazing. Talk was amazing, and your research into utilization of the median branches and the rail branches to separate, to have a function, finger flexion, supination, pronation. It's really amazing, and thanks for this wonderful talk. I think there's a big scope in the coming years for all transhumeral amputees with this targeted muscle reinnervation. Definitely have the great scope in moving towards the prosthesis, especially the case where they don't deserve a hand transplantation. We have a couple of questions to the panelists. We will start with Professor Dr. Bhaskaranand. The question is that when do you start doing the surgery in mirror hand? When do you do polycization? And at what age do you do polycization? And which thumb, which finger you create as a thumb? What is the criteria that you decide that this will be the thumb?
Yeah, there are extra fingers. There are extra fingers on the lateral side. Among the abnormal ones, we look at which is a better one. The best one is selected for polycization. One advantage we have is we can borrow certain structures from the neighboring structures which we are going to sacrifice. And skin is in abundance, so web space can be really created very well. I usually do the polycization after about, in general, after earlier I used to wait 6 months, but now I'm doing it after 1 year because structures are big enough. But most of my children came to me at the age of 2 and subsequently 5 and all that. So however late they came, I did the polycization first. Then at least they come to me only later when it is very acute reflection. And all the cases which I have done, about 4 cases, also with the osteotomy I did because there were no extensors really working, to which we could add the flexors, wrist flexors. So polycizations I have already talked, and wrist stabilization also we can do. Elbow in general, I'm not happy about the results that I had.
Yeah, thank you, sir. The other question is to Dr. Jenshen. There are 2 questions I'll club together. In a cleft hand, how do you decide which finger will be used as a thumb in correction? I'll repeat the question. In a cleft hand, what makes you to decide that this finger will be used as a thumb?
Design the therapy treatment complicated syndactly. Like type 3, type 3 is the thumb and the index finger is complicated syndactyly. I use a small little procedure and release the first wave space and to treatment syndactyly. And if several fingers syndactyly, I also I in the stage, the first stage is release the first web space, and the next stage will release another web.
Okay, thank you. The other question to Dr. Takaki, can you make a prosthesis which can detect sensation?
A sensation? We've never made a sensation yet, because it's difficult. But the construction is enough. No, not now.
Okay, thank you. The other question to the panelist, do you use mirror therapy for plasticity post-operatively, or do you use the mirror therapy? Having a mirror and with a normal hand functioning, ask the other hand to move. Do you use the mirror therapy for plasticity to stimulate the normal hand movement?
Yeah. Reinnervation starts 6 or 7 months after the surgery. I think they can move their fingers, possessive fingers, after the therapy.
Yeah, thank you. I have a personal question to Dr. Takaki.
Yes.
Do you still prefer to have a transhumeral amputee on one hand, or you prefer to have a transradial or below elbow amputee, which gives a better result in terms of getting a target muscle reinnervation? Because you have better length, you have more nerves, you have more muscles. What do you suggest, to have a transhumeral amputee a target muscle reinnervation, or a below elbow amputee to have a target muscle reinnervation?
Below AMCs, transradial AMCs, I think need for TMR because the muscle for the wrist and the finger motion, the left other person forearm. So I think we don't need TMR.
The question is because there are certain areas in the world where you may not be amenable to hand transplantation. Thus, your processes with TMR can help in such cases, preferably in a below elbow amputee.
Below amputee, yeah. I think process is easier way for acquiring the function.
Okay, thank you. Another question to Dr. Chen. Do you have any tip necrosis after this no littler flap? Because the surgeon who asked had faced many, few cases with the distal flap necrosis. Is there any recommendation for the flap design to prevent flap necrosis, especially in a snow littler flap?
Small radial flap. Small radial flap.
Yeah.
Is designed for the crosses ring finger and index fingers web.
The question is, how do you design a flap so that the skin flap may not go into necrosis?
This flap design depend on the wider of cleft.
So the flap design is based on the cleft pattern, and you prefer to have a wider flap design to avoid the flap necrosis.
Palmar flapness, you can keep the perforator of the artery. So I didn't change the dressing after one month. So didn't find the analysis of flap.
Okay. Thank you. We have come to the end. We actually have we have one more question to Dr. Professor Bhaskaranand. I think probably you have answered the question. I'll put it in a better way. The fingers, how actually they compare or match the opposite thumb. You do a position in a mirror finger, you find a suitable thumb. Do you really find it matchable to the opposite hand, or what is your outcome about regarding the length of the your precise thumb?
Length, there may not be any problem. But function-wise, if you ask me, out of the 9 polygations I have done, I think 3 of them give excellent results. The remaining are a bit stiff at the base and movements are not that good. Because we know, unlike in hypoplasia grade 5, that thumb may have a very good abductor, dorsal introitions, and usually such cases do very well compared to one with radial cleft hands, because radial digits also are inadequate. Similarly here, the lateral digits, among them the best one we select, and I should say excellent result I got in 3, almost comparable of the six. The remaining 6 did not behave that way. In one case I felt it almost poor, but patient is quite happy about it, about which I have nothing to say. So we do a functional evaluation of all the patients, being the JAMR meter, pinch meter and all that, all polycystic patients. We have found that we have done very well.
Thank you, sir. We have come to the end of the session. We'll have a quick closing remark from all these 3 panelist speakers. We will start with Dr. Takaki. Closing remarks.
Okay. Thanks for inviting us such a great meeting. I will come back to participate in the next meeting, and we want to discuss actively more. Thank you very much.
Yeah, sure. Thank you. Dr. Shen.
What's
your closing remark?
Thank you. Today's journal club.
Yep.
Thank you, Terrence. Thank you your invitation. So, I was amazed by the Dr. Braskin. He has so many cases of middle hand. I have only one case of middle hand. It's interesting. These interesting cases.
Yeah. Thank you.
Thank you.
Professor Bhaskaran, sir.
Well, first of all, I should thank you because the other 2 lectures fascinated me. Left hand, of course, I also do it, but I'm happy that she is recommending more of leafless procedure, quite a few people are not happy about it. I'm also very happy about it. Maybe from the beginning I've been depending on that. Regarding the prosthesis and all that, it's fascinating. Akaji's talk was really thought-provoking. It's not for me, it's for the next generation.
Exactly.
I'm not young enough to learn that and do it, but I'm sure that if there are patients, I'll send them to Akaji so they can go. Good. Very nicely organized. Terrence, you are
Sir,
great.
thank you very much.
Thank
Sir. Thank you very much for kind words. We are closing the seminar with this functional, this remark. The congenital hand are no more a social stigma. So we are the pediatric hand surgeon here, who are here to help you all. Even the rarest of the rarest possibility, like mirror hand or the cleft hand, or even the transhumeral amputees. With this final brief words, we wish you all happy, stay safe, and we will meet you again in the another journal club. Thank you all, and stay safe. Bye bye.
Bye.
Bye.